Did you know 1 in 2 women wear the wrong foundation? Matching foundation is hard, but Il Maquillage makes it easy. Take the Power Match quiz to find a better match in seconds, customized for your unique skin tone, undertone, and coverage needs. With 600,000 5-star reviews, this best-selling foundation is going viral for a reason. Available in 50 shades of weightless natural coverage. And with Try Before You Buy, you can try your full size at home for 14 days. Just pay shipping. Take the quiz at ilmaquillage.com/quiz. That's ILMAKIAGE.com/quiz.
Millions of people have lost weight with personalized plans from Noom. Like Evan, who can't stand salads and still lost 50 pounds.
Salads generally for most people are the easy button, right? For me, that wasn't an option. I never really was a salad guy. That's just not who I am. But Noom worked for me.
Get your personalized plan today at Noom.com. Real Noom user compensated to provide their story. In 4 weeks, the typical Noom user can expect to lose 1 to 2 pounds per week. Individual results may vary.
It took a lifetime to find the person you want to marry. Finding the perfect engagement ring is a lot easier. At BlueNile.com, you can find or design the ring you've always dreamed of with help from Blue Nile's jewelry experts who are on hand 24/7 to answer questions. And the ease and convenience of shopping online. For a limited time, get $50 off your purchase of $500 or more with code LISTEN at BlueNile.com. That's $50 off with code LISTEN at BlueNile.com.
Pursuing your future doesn't end at 40. In fact, it may mark the beginning of knowing who you are, what you're capable of, and what you really want. But knowing what's next and how to get there can be a challenge, especially when old narratives play on repeat. Liberty Road is here to share stories so that you can consider your possibilities, pursue your purpose, and move into your future with intention. I'm your host, Netta Jones, and we're here to listen, learn, and liberate dreams, one episode at a time. Well, hello, Liberty listeners. Welcome to another episode of Liberty Road. Today, you guys are in for a real education. You get to hear from Dr. Sameena Rahman. I got to interview her at our dinner in Chicago, and she brought it. Just an absolute wealth of knowledge. And I'm so glad that we have this time with her today. Dr. Rahman, welcome to the show.
Thank you so much. I appreciate you inviting me, and I love everything that you're doing.
Thank you. Thank you so much. Well, let's get started with who you are and what you do so that our audience has a little context. You're an OBGYN in the Chicago area, and you have really become an advocate and a leading voice through Gyno Girl, your Instagram platform, but beyond that, in this menopause and women's health conversation. Why was it important for you to use your voice outside of your practice, outside of your inpatient conversations? Why was it important for you to build this platform and go beyond that?
I've been practicing gynecology. Actually, in September, it'll be 10 years that I've had my own practice. And so when I branched out at that time from academic medicine, I really, wanted to focus on just being able to educate my patients when I see them in the office. And then what I saw was, as I joined Instagram probably like 6 years ago, there was a lot of misinformation and confusion. And I have patients come in all the time, like, I saw this on TikTok, I saw this on Instagram, I read this on Google. And so it was confusing for them a lot to see, what is the real deal when it comes to hormone therapy, when it comes to sexual dysfunction, like, what am I missing here? And for me, like, I love educating my patients. I have a podcast myself, and I always say that I'm here to educate so you could advocate for yourself. Because if women get the information they need and they get educated on something, then they can work with their clinician or whoever's helping them to make the choices they need for themselves, right? And so what I found was so much misinformation, so much confusion that I thought, like, I'm a board certified gynecologist. I'm on the board of the International Society for the Study of Women's Sexual Health, ISSWSH, which is like the premier educational and research organization. I've been part of their organization for 8+ years. I work with the Menopause Society. I'm really much entrenched in research and academia to that extent, even though I'm a private practice doc. And I just wanted to be able to get the right information out there. And I just love doing it. I love interacting with people from all over the world through my platforms. I love getting students come through, so it's just a great way to reach more people than just the number of patients I see in a day.
What you just said, was it educate so that they can advocate? Is that what you just said?
Yeah. Mm-hmm.
I saw it firsthand when we were at the dinner together in Chicago and you were on the panel. I was interviewing you. Afterwards, I was sitting with a group of women at the end of the table and we were enjoying our popsicles because it was so stinking hot in that room. And they started to ask me questions. Do you know if Dr. Rahman does this and that? And, a friend of ours just told us about the pellet. And apparently they were a little confused about where the pellet actually goes in one's body. Yeah. And I was like, you need to go right now at the end of the table and talk to Dr. Rahman. She came back and she said, I just made an appointment for myself and my girlfriends. And I thought that's exactly what happens. From your educating them, during our interview, they could now advocate for themselves. She physically got up from her side of the table, went over, spoke to you, booked an appointment, and now her health was in her hands. So I got to see that firsthand. That must be a real joy for you to see.
It was very nice. And I've seen a number of patients from that dinner at this point. So I think the message was clear that, if you're not getting the help that you need in navigating your midlife journey, you have to find someone that can help you, that's going to listen to you. And that's one of the things I always, when I talk to other people who are in different states or countries and they inbox me or they reply to something I wrote, because I have a Gyno Girl TV YouTube channel as well. And so between the podcast, the YouTube, and the Instagram, I hear from a lot of people on a lot of platforms. And when they tell me, I really don't, I don't know how to talk to my doctor about this. And I'm just like, if you don't feel heard, we have to find someone that can hear you, or you have to directly tell your clinician that you're working with, I'm not feeling heard. We know implicit bias is real in medicine, just like anything else. And we know there are some limitations to what can happen at a normal visit in normal practices, right? The system is actually rigged against women in so many ways. If you have to see 40 patients a day in a practice that is only there to generate revenue for the powers that be, it's really hard to say, I'm going to sit here and spend an hour talking to you about the last 10 years of your journey and try to understand what you've been through so that I can navigate the next 10, 20, 30 years with you, So I think that I always tell patients that, and people that DM me, you got to find someone. These are the organizations I'm a part of. There are other clinicians that are like me all over the country and also all over the world. It's just limiting in some countries, I think. So I find that to be, a little bit more difficult. Patients find it a little more difficult because they don't have all the resources.
Sure. Well, and I think the work that you're doing, both in advocating but in educating, is going to move the needle, not only for patients, but also for the system. The system is going to have to change because people will demand it and they'll seek other options. And at the end of the day, there's a business involved here and people are going to have to figure that piece of it out. Let's talk about Gyno Girl for a second. You talked about the podcast, Instagram, and your YouTube channel. First of all, can you please tell the story of how that name came to be? Because it's such a cute story.
Yeah, it's interesting because when I was a resident and medical student residency, one of the shows that kind of got me through that was this show called Scrubs. I don't know if I told the whole story last time, but the show called Scrubs that was very popular. It was medical comedy. And they had a session where they talked about here comes the Gyno Girls, they're a bunch of sorority gynecologists. And I always liked that. And the one part I didn't mention was when I used to live in Los Angeles. It was my first job out of residency. I worked at USC, and I had the opportunity to go to the Emmys my first year. And I actually met the cast of Scrubs at the Emmys. Yeah,
that's fantastic.
They probably won't remember. Yeah, it was really cool. And I was like, you guys, I'm actually a gyno girl. I was like... And for some reason, so a couple of them just wouldn't remember my name. They just called me the Gyno Girl because I think, whatever. So that's how I just kept the name. And then my husband and my kids and I both love comics and we love superheroes and all the things. So we decided to reappropriate instead of being a sorority girl, Gyno Girl, Gyno Girl is a superhero who, and if you've seen my logo, I have on my chest a uterus, tubes, and ovaries, and I'm flying through them. So protector of the pelvis, slayer of the stigmas around sexual health. This is the kind of stuff that's on my YouTube channel.
I love it.
My son says, it's kind of cringe, Mom, but...
Yeah, that's okay. That's what all of our kids say no matter what we do. So that's
cringe,
okay.
Mom.
Just tell them it's not forgettable, which is the real point, that people will remember it. And again, this is something that has really started to gain a large audience. Like people are tuning in, they're paying attention, which is for all the things that social media can be. The damaging, the difficult. I think one of the things, especially as adults, is that we can really use it as a tool to spread correct information, as you talked about. There's so much misinformation out there. But what I love about it is you're sharing, but you're also bringing other people on, other experts, and you're sort of building this bigger network through Gyno Girl. How much of that platform has informed your work, both as a practicing doctor, but also as an advocate and somebody who, I have a stethoscope in this hand and a megaphone in this hand?
I think it definitely, one feeds the other for me. And if you're on Instagram and you know that, I don't know, a few months ago, my friend and colleague, Dr. Mary Claire Haver, we got together to talk about this article that came out in the Lancet about, over medicalizing, menopause and this kind of thing. And we all eventually became like a big text chain of a bunch of different social media doctors, I guess you'd call us. Yeah. And so we call ourselves a menopause, which, some people also find cringe. But
it's okay. It's
but
okay.
I think that it's memorable. But I feel that all of us who are trying to really advocate and move forward the needle when it comes to midlife women's health really do use whatever research. We share articles with each other every day. Like, did you see this article? This might be something that's going to be cutting edge. Like, we got to think about, what's happening with the brain. We got to think about what's happening with the heart, everything. And so research and the patient care that we do, like when I see a patient in the office and I feel like, oh my God, this story is incredible. This poor woman suffered for 10 years. She was told, maybe your husband should do better. Oh, women's bodies are made for this. Like you hear all the stories that patients get told as they're either getting gaslit or getting neglected, that this is a natural stage that you shouldn't have to do anything about, that you should just, grin and bear it kind of thing. At that point, I was like, these stories need to be told too. I also have interviewed some of my own patients on the podcast who, I was like the 7th or 8th doctor they saw, and they were finally like getting the relief they needed, and they wanted to be a voice. They said, can we tell our stories? I found that, just having that ability to transition from, here I am teaching you, and now you can go out and teach others. That's right. Like you can tell about your journey, because you can learn so much. Even if it's not just the medical jargon, you can learn from someone's journey and what they learned and how they advocated for themselves. So I think one definitely feeds the other. Like whatever I'm doing in the office is feeding my platforms, and my platforms, are feeding like what I do with my patients. Sure.
It's also interesting. And I'm sure all of you within the menopause. By the way, what's truly cringe is that these women have to go through this. It's not menopause and Gyno Girl. It's that these women have to go through this.
Yeah.
But we had an event, a local event in LA for Dr. Sharon Malone. And it was interesting to me, as I was interviewing her, we had about 65 women there. And I feel like we've been in this menopause space for a couple years now, right? Like in terms of course, you guys have been in it for a lot longer, but we as an audience have been privy to this new information or a new way of looking at the studies, that we're looking at hormone therapy as viable. It's not an automatic no. And yet I was shocked at how many people in that space were having aha moments, and how many people were doing the slow nod, like, yeah, that's me. She's describing that. I had no idea that was a perimenopausal or menopausal symptom.
Right.
And so this work is really in its sort of nascent stage, even though we're hearing about it more and more and it's lifted off. There's more people to reach and more stories to tell. And again, in the words of Dr. Sharon Malone, we don't really have to suffer. Right. Maybe it's bred into us as women and as mothers and as child bearers that suffering is a part of the role, but we don't have to. How much of that do you think we have sort of assumed that role, that, that's just a part of what it is?
Oh my God, like everyone. I think that it's interesting. There was, the big New York Times article that went viral about a year and a half ago by Sue Dominus. Women have been misled about menopause. I think that was, a real jumping point for a lot of people. But when she came and spoke to the Menopause Society last year, she said that, this consistent theme that she found, and I think most of us that take care of patients with this also find this theme, is that women are accustomed to suffering, right? Like pelvic pain, the pain around your periods, sexual pain, it's normalized. And then, clinicians are telling them that this is normal and that this is just a normal part of, their everyday being. That I think the suffering of women is just so entrenched in patriarchy and misogyny and all the bad, all the things that you think about that have limited access for women for so long that women believe it. Sometimes just even now I had a patient who, I was trying to do a procedure on, and, we tried to give all the anesthetics, and she was like, I'm so sorry if this is difficult for you. And I was like, you don't need to apologize to me. You're the one in pain, we're trying to make you comfortable. But she was okay suffering. She was just worried that it was affecting how I was doing the procedure. And I was like, no, listen, we're not, this is not anything, but I think it's just so ingrained. And she was, 20 something year old. I see the same in my 40 and 50 something year old patients where they're just like, oh, this is just what we have to do, or this is what my mom told me. And culturally, I feel like it's a big factor, right? I think as a woman of color, I think in the South Asian community, I think in the Black community, some of these communities are so family oriented. And so sort of like the family is entrenched with everything that's done. Yeah. That if your mom told you that, this is part of what life is, and we're not going to even talk about it, but I went through that, but you're just going to have to deal with it. Just like I have patients when I did OB who would be like, I'm not getting an epidural because my mom told me that, it's okay for, what I'm saying? It's like this culture of acceptance. Yeah. And to Sharon's point, absolutely, women should not and do not have to suffer like this. I was like, give me my epidural at 2 centimeters. I don't care. I'm not suffering. Well,
there's a weird badge of honor that's somehow associated with some of the suffering. My family were Egyptian, and there's some of that tied into it too. Sure. That cultural women are you show your strength by going through this and not complaining, which is all ridiculous and unnecessary. I think that it's a misnomer to associate that with any sort of identity or strength or otherwise. Right. What would you say from the article that came out? And let's just wrap it up in the last 2 years, where we've seen more people advocating for menopause. We've seen more brands, products being developed for both peri and menopause, and an awareness. What would you say has been good about this sort of boost, and what would you say still needs to be done?
I think that it's great that more women are talking about it. Women are trying to be innovative, trying to redefine who they are in this midlife period by saying, this is what I went through. This is how I did it. Maybe I could find a way to help other women. So I find that to be a big narrative on many platforms. And I love that. I love the fact that, we can uplift each other as opposed to being like, no, you need to suffer and that's okay. Yeah. But I still think we have a long way to go because, the more we talk about those of us. And like I said, I never push hormones on anyone. And I think that it's a very personal choice. But I do want people to know the safety and efficacy and the profiles and the actual data behind menopausal hormonal therapy, whether or not it's estrogen, progesterone, or testosterone, whatever we're treating and whatever we're trying to get through. And what we find happening is a lot of times, the other side is oh, now you guys are trying to do too much in the medical field for this natural part of life, right? So we're getting this pushback a lot too, that, oh, this is a natural part of life. Sure, it is a natural part of life. Pregnancy is natural too, but at some point, 1 in 3 women were dying for pregnancy or, back in the day. And so, you feel like there's always going to be that push and pull because there's some people who firmly believe that nothing should be done, that this is just, we shouldn't over medicalize things. And then other people want to know the data. How can we advance as a society? People are living longer. Longevity is very important. Quality of life is very important, right? Yeah. I think the big issue is too that we see so many of our parents and their generation who are now suffering with dementia, who are suffering with incontinence issues. They're suffering with a lack of mobility because of their falls and all the things. So, as someone who's in the sandwich generation where I have kids, but I also have been dealing with either in-laws or parents that have these, I want to be I don't want my kids to have to really walk me through that and don't do that. And B, I don't want to live a life. I mean, I'm sure they didn't want to live a life like that either. But as a child of immigrants, they're always in fight or flight mode, right? They're just trying to survive. And now they're at a point where, okay, they've survived all of this, but didn't think about their health beyond age 50 or 60 because most of their parents didn't live beyond that time,
Sure.
you know? And so I think that there's a lot of work to be done. I see a lot of sliding back towards some of that ideals. I just feel like women should not suffer, and there are options for them. And if they choose not to do them, I'm always willing to meet a patient where they are, you know, if they're not, but I just want them to know what's
available.
Available.
And the data, the real data around it, because we have to right the wrongs that were done all those years ago. It's interesting as I'm hearing you talk about this, and I'm not a doctor. I know no part of this study, but I'm just taking the words that you just shared about this study or this article that came out about over-medicalizing. Am I using that correctly? Yeah. It's interesting that we don't talk about things that are all natural, if you will, when we talk about pregnancy, to your earlier point, or when we talk about, right, like it's totally fine for us to get the support we need medically, hormonally, if we don't want to have babies and we want to, right? Like people have been on hormones for a long time, which was another thing that was shocking to me. Why all the hubbub around hormone therapy in menopause, but none of it around it in childbearing years? There's still hormones. Like what is it that we are caught up in? And the other thing is, and you'll be able to speak to this, but I know I think it's in England, they have started to socialize the care around UTIs for older women because they realized how many of these women were going into the hospital. They were taking up beds that they didn't need to take up, or they were actually getting really sick and dying from UTIs. Sure. These are things that if we know better, we can do better. And there's no such thing in my book as over-medicalizing. We need to know how to care for those things. So what do you say about that?
It's so interesting. I'll give you an example. There's, Dr. Avram Blooming, Dr. Cornman, they're all big advocates for hormone therapy, and they've dealt a lot in this breast cancer field, right?
And let's just point out for those people who don't know that Dr. Avram is a male.
He's a male, yes.
Yeah, and has been around for a long time. Yeah.
Yes, and he's a medical oncologist. He treats breast cancer. So his book, and Carol Tavris' Estrogen Matters, which it's coming out again, like it's getting reprinted with updates. But anyway, there's some good points that are made in that if you look at like a woman when she gets diagnosed with like early breast cancer, like in her 30s, a lot of times after their treatment, maybe they do tamoxifen, whatever, their treatment after, lumpectomy or, whatever treatment they're getting. And Dr. Men, actually, she always tells a story about how she was encouraged to go ahead and try to reproduce while she could in this period of time after her treatment, right? Because that reproductive potential was so important. They thought it was so important to her. It must be so important to people in general, right? Your reproductive capacity. Yeah. But after you're in menopause and after you have a breast cancer patient who's survived in the post-menopause, her quality of life isn't important enough for you to really consider and you're talking about someone getting pregnant and you have 1,000 times the amount of hormone that you'll have in the little bitty amount that we give some people in post-menopause. Yeah. And so you're giving them high loads of estrogen, progesterone, getting them pregnant, whatever. I think it's very interesting because it's all about reproduction, right? Because then when a postmenopausal woman is suffering, or a menopausal woman, her reproductive capacity is not there anymore, but her suffering isn't as important either, right? Oh, you're just old woman, you can take it.
Yeah. It's we're going to put you on the shelf. Yeah. We'll deal with this later. Yeah. Yeah.
Not to mention, cardiovascular risks that go up, like dementia, all the things that happen as we lose estrogen. It doesn't matter, right? You can this is just part of aging. Yeah. And so it's interesting the dynamics that change when someone's younger and when someone's older, suffering in different ways. But to your point about vaginal estrogen, you're talking about when women in their 80s or 70s get a UTI, a urinary tract infection. We're talking about sort of one of the aspects of the genital urinary syndrome of menopause, which is really how the vagina, the vulva that starts shrinking, the clitoris shrinks. The vaginal tissue changes, the pH changes, and frequency, urgency, and UTIs come up. It's not just vaginal dryness. And I often say that it's really using vaginal estrogen that prevents those urinary tract infections is life-saving, right? Because if you have an 80-year-old woman that gets a UTI, she's going to get delirious, first of all, right? Because infections cause that in that age population. And then all of a sudden, if it moves from the urine to the blood and you get urosepsis, I think that's about 25% of all geriatric hospitalizations. It's like 6 to 7% of those women die from a UTI, right?
Yeah.
And this is totally preventable by something that's safe for almost everyone. It's a vaginal estrogen. It's not absorbed systemically. It's locally absorbed. It prevents UTIs. So it's really not just even about vaginal dryness or painful sex. It's about like a life-saving measure for those patients who would normally be hospitalized because of it.
Yeah, I mean, if a country is socializing it and institutionalizing the distribution of it, there's got to be some economics behind it. You can believe that. Never mind saving lives and saving people from pain and all the people that are affected, not just the woman, but the caretakers overburdening a hospital unnecessarily because we haven't paid attention to women's health. It doesn't seem like it's rocket science here. You've talked about misinformation a couple times. What do you think the biggest misconception or misunderstanding around perimenopause and menopause, or, you know, around those two actual things, but also around the treatments for them?
Yeah, I mean, I think there's a lot of misconceptions, you know, some of them being that like you can't get treated until you've had your final period. I think a lot of people get told that. I have a lot of patients that come in and say they've been suffering with perimenopausal symptoms for years, but they're having these irregular cycles. And they were told that, you know, they had to wait until their final period to get treated, which is not true. We treat perimenopausal symptoms all the time. Sometimes people get birth control pills to treat some of these symptoms because they need contraception still, or they have, you know, issues around bleeding that might be helpful. But most of the time you can get standard menopausal hormonal therapy in that perimenopausal period. And we do full replacement on women who enter early menopause less than age 40, so premature ovarian insufficiency. So those people actually need a full replacement. That's one of the biggest misconceptions. I think, you know, just misconceptions around hormone therapy still exist, right? Like even among clinicians, right? If you're still living in 2002, when the Women's Health Initiative was really bombarding the media and everyone in the world that, you know, there's this huge risk of breast cancer and women will die from this if they take it kind of thing. You know, that's just still prevalent. That is really... Dr. James Simon, I remember listening to him for the first time years ago, and he said it's like a zombie idea, like it just won't die. Yeah. So I think that it's something that's still present, it's still pervasive, and even among clinicians to this day. Like as a clinician, you can choose to be complacent in like, okay, I'm just going to remember what I learned in residency, and then I have to do my CMEs every year. But really to stay on top of things, like I go to 4 or 5 conferences a year in my areas of sexual medicine, menopause, and vulvovaginal disease. And I always say, like, I'm just trying to keep my finger on the pulse of the latest research, you know, meet the latest people doing the cutting edge stuff for my patients, right? And I'm also a solo doc. I have, you know, a nurse practitioner and I have a pelvic floor therapist, but I'm not working with a bunch of clinicians that I can just say, hey, what do you guys think about this? Like, I actually depend on my menopause and all these people that I meet everywhere to like bounce ideas off of.
Which it seems, whatever your professional track, that should be something you're doing at this age, right? So we're talking about, our whole platform is about women in midlife, and it's around vocation and kind of what are you going to do next? You got to stay abreast of things. You got to know what's going on. There's no reason for us to be hanging ourselves up. We don't need to be retiring in terms of our education.
Absolutely.
And I think specific to your education, we know that menopause as a science to be studied in med school was like a day or a thing that you guys had to go through. Like, we have to go sit in on this seminar or whatever, that it's not something that's independently studied. So to be able to go back and learn what the new research reveals and shows, I think is, I mean, it would be, I would think, incumbent on the doctors to want to do that just out of integrity, if nothing else.
Absolutely.
Some people are getting a little like, okay, I've heard a lot, menopause. What do you not want people to miss? Like, yes, I know for those of you who are reading a lot and you're on Instagram and YouTube and listening to podcasts and all the things, maybe it feels like you've been hearing it a lot, but what don't you want people to miss in all of it?
That's an interesting question. I had recently, someone had told me that, like, what is everything perimenopause then? Like, she was like listing all the symptoms. And I'm like, well, yeah, that could be, that sounds like perimenopause. And she's like, everything I'm having is perimenopause. And I'm like, well, I mean, estrogen receptors from head to toe, like, it's very possible that your vertigo or your palpitations, all of the things are related to these hormone deficiencies. And what's interesting is, like any other hormonally deficient state, like we actively treat thyroid disease, we treat diabetes, we treat all the things that are hormonal deficient states, except when it comes to like menopause and perimenopause, right? So it's a state of a deficiency of multiple hormones. And we don't actively go and treat them unless patients have a symptom or patients are trying to prevent osteoporosis or they have low sex drive. I think it's important to remember that it's not just about vasomotor symptoms, the hot flashes and night sweats, that there are multiple other syndromes associated with this transition. We just talked about the genitourinary syndrome menopause. There's recently, Dr. Vonda Wright just published on the musculoskeletal syndrome of menopause, which is a huge leap, I think, in terms of, all the muscle aches and frozen shoulders and all the things women experience. And then, I think there's just going to be more and more that we see when it comes to cardiovascular health and brain health and everything else. Of course, right now, the main indications are around, prevention of osteoporosis, prevention of genitourinary syndrome menopause, treating those vasomotor symptoms. But the other thing I want people to remember is that what I see as a big symptom that patients complain about all the time is just that I don't feel like myself. I don't like who I am right now, right? I just, this is not me. I'm not this person that gets anxious getting on a plane. This is not me. I'm not this person that just yells at my kids all day. And my kids tell me that, or my husband tells me that, so patients tell me that every day. And I just want to validate that this is a big transition in your life, and that, if you want to go through this transition easier, you can find someone to help you through that. And if hormones is not what you want to do, there are other things that can be done and maybe more beneficial for you. But you should know all of your options. You need to know what your toolkit is. You need to know how you need to exercise in certain ways, or modify your diet, or, make sure you're getting sleep and reducing stress, and all the things that we know just compound on a midlife woman, right? I would say midlife is like the worst time for all this to happen, because you might be starting a new career. You might be at the pinnacle of your career. You might be dealing with your parents who are sick. You might be raising kids. You might have all of that. You might be going through divorce. You might be dealing with death. And it's just all coming at you at once. And then just throw in the like hormone stuff,
No, it's true.
As if you don't have anything else to deal with. Let's just mess up your hormone status too and see what happens to you.
I had to hear somebody else talk about, she referred to it as rage, but she's like, I just have this sort of anger or this rage that's coming out. It's not even warranted, but I can just feel it, and I'll blow up, and that's not who I've ever been. And it was when that person associated that with hormones that I was like, oh, yeah. And I am dealing with frozen shoulder right now. We're actually having Dr. Vonda Wright on the show in a few months. Can't wait to ask her about that. The biggest thing, and again, like you, I want our listeners to hear this and know that this is a very personal decision. I did choose hormone therapy for myself. And the thing that it alleviated right away, that I felt, right away being a few months in, was the extreme joint pain that I had been feeling in my hips, in my knees. And I'm dealing now with arthritis in my thumbs, like all the things. And I didn't know what was what. I didn't know what was, I continued to have sporadic or erratic period. I am now 56, but at the time was 54. And it was really wanting to figure out what is hormonal and what is not. I was concerned about my brain fog. How much of this is hormonal and how much of this is some sort of early onset something else? I didn't know. I don't know what I don't know. And so I think trying to pull those things apart and understand them for what they are, instead of just saying, this is natural, this is just a part of life, I think is an important message that you guys are spreading, and one that I think we really need to consider for ourselves, not to just try and walk through this. By the way, this can be 10 years, right? We can be in this season for a really long time.
This transition, yeah.
And
I think it's just that whole roller coaster of high hormones, low hormones, high hormones, that really has such a detriment on patients. And then I have patients that come in and they're like, oh, I had menopause 3 years ago and I kind of breezed through it. And I'm just like, That's wonderful.
Yeah, congratulations.
I'm so glad to hear that.
Yes.
But it's not the majority of women.
Yeah.
You know?
Yeah.
So.
Yeah, absolutely. Yeah. And it's funny, you were talking about families earlier. When I asked my mom, I think she just doesn't totally remember. She was too busy with, life.
Yeah.
But she's like, oh, I don't think I suffered from anything. And now she's dealing with some things that you can tell that whether it's UTIs or thyroid issues that probably could have started to get dealt with back then had we been where we are now. What are some resources, maybe top 3 resources, books, podcasts, aside from Gyno Girl, of course, and your own podcast, that you might recommend for our listeners if they want to just dig a little bit deeper and maybe understand their own symptoms? Any that you recommend?
We follow guidelines by Menopause Society. So menopause.org has a lot of great information. Even my Sexual Medicine Society, ISSWSH.org, www.ISSWSH.org is very good. We have plenty of our friends and colleagues who have written great books that are really evidence-based. Dr. Mary Claire's New York Times bestseller, The New Menopause, Dr. Sharon Malone, Grown Woman Talk. Estrogen Matters. I mean, that book, it really just so much was like all the research in one place and really eye-opening. I think it was just a great resource. I have patients come and tell me that they read these books and they want to talk to me because of that. Yeah. My friend Kelly Casperson's podcast. Oh, Dr. Lauren Stryker has a wonderful menopause podcast. It's great. She's very evidence-based and detail-oriented in that as well. And so there's just so much great information out there. It's hard to sift through it. But I think, finding someone who is experienced in menopause, looking at their credentials and trying to figure out, where they're coming up with their data. But those people for sure.
Yeah. And I would also say the 2 books that you mentioned, both Dr. Sharon and Dr. Mary Claire's 2 books, are pretty easy to navigate. Yeah. They're not overwhelming. It's not a ton of medical jargon that you can't sift through. There's some lovely storytelling in it. That's it's I think just for our listeners to know that they're pretty accessible. Yeah. So we have just started this new thing where we're allowing our Liberty Road Insiders, which is our member community, to ask a podcast guest a question. This guest actually asked to remain anonymous, but I want to bring her question to you. So it is, let's see, I'm barely 40 and experiencing pelvic floor weakening. I feel like I'm losing control of my bladder. What type of specialist should I see? And is there anything I can do from home to regain control?
The bladder pelvic floor dysfunction is very common. I think, for almost every patient I see probably has some form of pelvic floor dysfunction. And of course, we see bladder leakage when you cough, sneeze, or laugh. We see sexual pain happening. We see issues with your bowel and bladder function. Those muscles are so critical for that. It's really important to find a pelvic floor therapist that can really help navigate you through that journey. When it comes to strengthening those muscles, you can have a high tone pelvic floor where the muscles are super hypertonic. They've become shortened. They've become high tone, increasing the amount of lactic acid, decreasing the amount of oxygenation, getting burning at the opening. You can also have a very weak pelvic floor at the same time. So, looking for a pelvic floor specialist that really specializes in mainly just the pelvics, because you can find physical therapists that kind of do both. And whether or not you can, there are probably some that can do both really well, orthopedic and pelvic floor, but a physical therapist that can really help you will be, I have so many physical therapists on speed dial for myself, and I have one in my office too. They're amazing. They're a big part of our team when it comes to midlife women, when it comes to sexual dysfunction, when it comes to, uterine prolapse, pelvic prolapse, stress incontinence, all the things. And seeing either if the incontinence, she said she was incontinent or she said she just had a leak.
She just says, I feel like I'm losing control of my bladder.
Oh, okay. So we know that after childbearing, going through these transitions in menopause, weight gain, weight loss, smoking, a lot of things can contribute to that. So pelvic floor therapy is usually our first approach to improving the pelvic floor, as well as getting treated for improving the incontinence. Then seeing a urologist or a urogynecologist. Those are the specialists that I would go for. And then within urology itself, there's also the same sort of thing as a urogynecologist where they're doing pelvic reconstruction. They're dealing with pelvic floor prolapse as well as stress incontinence. So those are the two big areas or two big specialists I would go visit.
Thank you. That's super helpful. Is that, just curious, can you have pelvic floor issues regardless of if you gave vaginal birth or had a C-section?
Yes, absolutely.
Okay.
There's some, studies suggest just even, carrying a baby can be enough stress on your pelvic floor. Kind of is genetic dependent too, like what's your collagen status look like. But, time, hormone status, and whether or not you're always clenching, anxious. If you're clenching your jaw, you're usually clenching your pelvic floor. So most patients nowadays have a certain amount of anxiety that really creates a high tone pelvic floor, which can really weaken the muscles down there.
Oh my gosh, I clench my jaw all the time.
Yeah, I know.
And you just mentioned collagen. Can we take collagen supplements for that?
To improve the pelvic floor? Not usually. I mean, they actually do some, and I'm not a specialist in urogynecology, but there are some collagen injections that can be done. There's procedures that are minimally invasive, and then there's slings, and then more aggressive procedures. Okay,
that's good to know. Thank you for that. I appreciate that. And then this has gone by so quickly, but I have to ask you, in launching, I'm going to call it your platform, All Things Gyno Girl, your podcast, your YouTube channel, your Instagram, and of course your practice, but specifically extending your platform. How has you growing your voice and your reach liberated you?
Oh, it's so liberating to be able to, I grew up as a people pleaser, I think. That's just kind of like who I was. And so as I've entered in my 40s and trying to really keep my own sanity and not doing everything for everyone all the time, I think just having the platform and saying, what I feel through an educational way to help others has really just brought me another level of, satisfaction and purpose, right? Yeah. I've always had purpose to help others, when it comes to medical stuff, but I used to obviously do obstetrics and do a lot of surgeries. And I have my colleagues who sometimes say, don't you miss those surgeries where you save that patient's life from an ectopic pregnancy or save that baby? And I was like, there was a time and place for that. Now my voice is really trying to get women to really embrace a good quality of life and improve their overall quality of life. And in that way, you're saving their life too, right?
Sure.
You're really helping them to save themselves. And that's what I'm here to do, help you save yourself, help you educate so you can advocate.
Well, it's always interesting to me when I ask this question, and the thing that liberates the woman is the thing that liberates so many women that you're in service to. So thank you for the work that you're doing, and thank you for taking the time to be on the show with us.
Thank you so much for having me. I love everything you're doing, and I look forward to working with you again.
Thank you. Thank you, Dr. Rahman. And to you, Liberty listeners, thank you for hanging out with the two of us, and we will talk to you guys again next week. Bye for now. Liberty Road is broadcast on all platforms: Apple Podcast, Spotify, Stitcher, Google Podcast, and more. If you like what you've heard, please follow, rate, and review Liberty Road on Apple Podcast and Spotify. It helps us to know if these episodes are inspiring and equipping you to move into your middle third with intention. Liberty Road is created by executive producer Netta Jones, supervising producer Elizabeth Wyndham, producer Julia Wyndham, and music by Jack Jones.
It can be hard balancing taking care of kids, senior loved ones, and yourself. Remember, it's okay to ask for help. There's a reason 29 million families have turned to Care.com. Find background-checked sitters, nannies, and senior caregivers who can help with everything from watching kids after school to senior meal prep. Whether you need full-time, part-time, or even occasional help, you can view rates and book highly rated caregivers that fit your budget and schedule. Get the help you need with Care.com.
First, the bad news. SAP Business AI won't generate amusing holiday cards, but it will personalize career paths for your employees and let you know which suppliers are best so you can be ready for the next opportunity. Revolutionary technology, real-world results. That's SAP Business AI.